Understanding oxygen transport balance and how to assess it is essential to being able to appropriately treat the various shock states. Whenever we are evaluating a patient in shock, there are four primary questions that must be answered. In this lecture, we will be addressing the fourth question: is oxygen transport balance appropriate? Let's begin by defining several terms. Oxygen delivery is the amount of oxygen pumped to the tissues by the heart. Oxygen consumption is the amount of oxygen consumed by the tissues. Oxygen demand is the amount of oxygen required by the tissues to function aerobically. During critical illness, the patient's demand for oxygen may exceed their oxygen delivery, resulting in anaerobic metabolism, cellular ischemia, progressive organ dysfunction and failure, and even death. As long as oxygen delivery exceeds oxygen demand, oxygen consumption plateaus and no longer rises in response to increases in oxygen delivery. This is the goal in oxygen transport resuscitation. Prior to this point, however, oxygen consumption is said to be supply dependent, as the patient's oxygen demand has not been met. The point at which supply dependency stops is known as critical DO2. We prefer that oxygen consumption is plateaued, so that there is a physiologic oxygen reserve in case oxygen demand increases acutely. As we have seen before, the circulatory system is two circuits connected in series. Each circuit has a pump, either the left ventricle or right ventricle, and a resistance, either the systemic circulation or the pulmonary circulation. Central to any assessment of oxygen transport is the ability to calculate the amount of oxygen in the blood at any point in the body. Such calculations are dependent upon the measured oxygen tension and oxygen saturation at that location. We use pulmonary artery and central venous oximetry catheters to help us assess oxygen transport balance at the bedside. Let's begin by learning how to calculate the content of oxygen at any point in the body. Oxygen in the bloodstream exists in two forms: that which is bound to hemoglobin and that which is dissolved in plasma. 98% of oxygen in the blood is bound, while only 2% is dissolved. The amount bound is dependent upon three factors: the hemoglobin concentration, the oxygen carrying capacity of hemoglobin, and the degree to which the hemoglobin is filled with oxygen, or its percent saturation. For humans, the oxygen carrying capacity of hemoglobin is 1.34 milliliters of oxygen per gram. The amount dissolved in plasma is dependent upon two factors: the partial pressure of oxygen and the solubility of oxygen in blood. For humans, the solubility coefficient of oxygen is 0.0031 milliliters of oxygen per deciliter of blood. Thus, for any point in the circulation, the amount of oxygen bound to hemoglobin can be determined by multiplying 1.34 times the hemoglobin concentration times the oxygen saturation, and the amount dissolved in blood can be determined by multiplying the partial pressure of oxygen times 0.0031. The sum of the bound and dissolved oxygen represents the oxygen content. From the equation, it is easy to see the minimal contribution made by dissolved oxygen and the overall importance of hemoglobin in delivering oxygen to the tissues. The oxygen content of blood as it leaves the alveolus is a special case that requires a brief discussion. Assuming the patient is on supplemental oxygen, the alveolar oxygen saturation can be assumed to be 100%. We can then calculate the alveolar oxygen tension using the universal gas law, which states that the barometric pressure is the sum of the partial pressures of the gases present. As nitrogen does not participate in gas exchange, we can ignore this inert gas. Rearranging, we find that alveolar partial pressure equals the inspired oxygen fraction minus barometric pressure minus water vapor pressure minus the arterial partial pressure of carbon dioxide divided by the respiratory quotient. For most purposes, we can assume that the respiratory quotient is equal to 0.8. If we assume that the patient's inspired oxygen tension, or FiO2, is 30%, we calculate that the alveolar partial pressure is 199 millimeters of mercury. For a rough approximation that can be rapidly calculated at the bedside, multiply the FiO2 times 700 and subtract 50. Now that we know the partial pressure of oxygen as a red blood cell leaves an alveolus, we can calculate the pulmonary end-capillary oxygen content. This is the oxygen content of blood as it enters the left atrium. We can assume that the oxygen saturation of this blood is 100%, barring the presence of significant lung injury. For a patient with a hemoglobin of 15 grams, therefore, 20.1 milliliters of oxygen is bound to hemoglobin, while only 0.6 milliliters is dissolved in each 100 milliliters of blood. It is important to remember that the alveolar partial pressure and not arterial partial pressure of oxygen is used in this equation. To determine the oxygen content of blood leaving the left ventricle, we calculate the arterial oxygen content. The equation is the same, we just use the oxygen saturation and partial pressure of oxygen for arterial blood. For a patient with a hemoglobin of 15 grams and an arterial oxygen saturation of 100%, 20.1 milliliters of oxygen is bound to hemoglobin, while only 0.31 milliliters is dissolved in each 100 milliliters of blood, for a total arterial oxygen content of 20.4 milliliters per deciliter of blood. To determine the oxygen content of blood returning to the right atrium, we calculate the venous oxygen content. We simply substitute the venous oxygen saturation and partial pressure of oxygen into our equation. Now, a normal mixed venous oxygen saturation, or SVO2, is around 75%. The PVO2 can be measured with a venous blood gas, but is commonly estimated as 35 millimeters of mercury. For a patient with a hemoglobin of 15 grams, 15.1 milliliters of oxygen is bound to hemoglobin, while only 0.11 milliliters is dissolved in each 100 milliliters of blood, for a total venous oxygen content of 15.2 milliliters per deciliter of blood. A patient's oxygen delivery can be calculated by multiplying blood flow by the content of oxygen. Since we always use indexed hemodynamic parameters to account for differences in patient size, the oxygen delivery index is thus cardiac index times the arterial oxygen content. We use a correction factor of 10 to correct for the fact that cardiac index is measured in liters and oxygen content is measured in milliliters. Assuming a normal cardiac index of around 4 liters per minute per meter squared and a typical oxygen content of around 20 milliliters of oxygen per deciliter of blood, we arrive at an oxygen delivery index of 800 milliliters per minute per meter squared. A patient's oxygen consumption can similarly be calculated. The cardiac index will be the same, but we use the arterial-venous oxygen content difference to reflect the amount of oxygen returned to the right heart. A typical oxygen consumption index would be 4 liters per minute per meter squared times an oxygen content difference of 5 milliliters of oxygen per deciliter of blood, resulting in an oxygen consumption of 200 milliliters per minute per meter squared. The mixed venous oxygen saturation is the saturation of blood returning to the right atrium. It can be measured continuously with an oximetric pulmonary artery catheter or approximated as central venous oxygen saturation using an oximetric central venous catheter. It can also be measured intermittently using a venous blood gas drawn from a central venous catheter. It provides an indication of the relative balance between oxygen delivery and oxygen consumption. As the flow-weighted average of the venous oxygen saturations from all perfused vascular beds in the body, it is an estimate of global oxygen consumption, but does not confirm the adequacy of perfusion of individual vascular beds. As oxygen consumption increases, the mixed venous oxygen saturation will drop. This can help predict oxygen transport imbalances and allow appropriate interventions to be made before the patient's clinical condition deteriorates. As a general rule, a low mixed venous oxygen saturation is always bad, as oxygen consumption is high or oxygen delivery is low, and the tissues are not receiving enough oxygen to avoid anaerobic metabolism. A normal mixed venous oxygen saturation is not necessarily good, as it does not identify individual vascular beds that may be poorly perfused. A high mixed venous oxygen saturation is usually bad, as tissues are either not consuming oxygen or blood flow is being shunted away from tissues and oxygen uptake is decreased. The oxygen utilization coefficient, also known as the oxygen extraction ratio, is the ratio of oxygen consumed to oxygen delivered. It is normally 0.25 to 0.35. It can be approximated as 1 minus the mixed venous oxygen saturation. So, as we have learned previously for preload, contractility, and afterload, we can use hemodynamic calculations to assess the oxygen content at any point in the body. We can also measure the partial pressure of oxygen and the oxygen saturation of hemoglobin at those same points. We use these parameters to calculate the patient's oxygen delivery and oxygen consumption, the numbers that really matter in shock resuscitation. To assess a patient's oxygen transport balance, we can use the parameters we have just learned to calculate to answer 4 important questions. First, is the patient's oxygen delivery adequate for their needs? In a critically ill patient, an oxygen delivery index above 600 milliliters per minute is associated with improved survival. If the patient's oxygen utilization coefficient is greater than 0.35, or the patient's SVO2 is less than 65%, it is likely that their oxygen delivery is barely meeting their oxygen demand. Remember that oxygen delivery is heavily dependent upon having adequate hemoglobin to transport oxygen. While the optimal hemoglobin remains unknown, evidence suggests that a hemoglobin above 10 grams during the first 48 hours of shock resuscitation is associated with improved outcome. Judicious amounts of acidemia, hypercarbia, and fever all produce a rightward shift in the oxyhemoglobin dissociation curve and may improve tissue unloading of oxygen. Second, is their cardiac index adequate for oxygen consumption? Begin by checking the arterial venous oxygen content difference. If less than 5 milliliters of oxygen per deciliter, cardiac index is sufficient to meet the body's demands for oxygen. A large percentage of blood returning to the heart is still oxygenated. If greater than 5 milliliters of oxygen per deciliter, however, an abnormally high percentage of oxygen is being extracted from the blood. Attempts to increase cardiac index should be undertaken to improve oxygen delivery. Next, check the patient's heart rate and stroke volume. High heart rates reduce diastolic filling time and can impair stroke volume. Inappropriate tachycardia should be corrected through fluid resuscitation, beta blockade, and correction of abnormal heart rhythms as appropriate. Third, is their oxygen consumption adequate for oxygen demand? Check a lactic acid level. If greater than 2 millimoles per liter, anaerobic metabolism is present, and both cardiac index and oxygen delivery should be optimized. The mixed venous oxygen saturation is helpful in interpreting the lactic acidosis. If SVO2 is normal, the lactic acid is probably due to prior anaerobic metabolism. If the SVO2 is low, anaerobic metabolism is likely still ongoing. Fourth, is the patient's hypoxemia due to a low flow state or a pulmonary problem? We have previously learned to use the arterial venous oxygen content difference to detect a low flow state that needs an increase in cardiac index. To determine whether a patient's hypoxemia is due to a pulmonary problem, we can calculate their intrapulmonary shunt. This is blood that passes through non-ventilated portions of the lung and is returned to the left atrium without becoming saturated with oxygen. Normal intrapulmonary shunt is 2 to 5% of blood flow due to 3 reasons. Bronchial artery blood, which enters the pulmonary veins after giving up some of its oxygen to the bronchi, coronary artery blood, which enters the left ventricle through the Thebesian veins after perfusing the myocardium, and blood that passes through normally collapsed alveoli in the apices of the lungs. It is commonly estimated using the alveolar arterial or AA gradient. Intrapulmonary shunt can be pathologically increased by one or more of the sources listed here. In some critically ill patients, intrapulmonary shunt may exceed 50% and manifest as severe hypoxemia. Intrapulmonary shunt is an example of an oxygen refractory hypoxemia. As shunted blood is not exposed to ventilated alveoli, it cannot be improved with supplemental oxygen, regardless of the oxygen fraction administered. In this two-alveolus model, note that blood returning from the right remains desaturated as it passes by a collapsed alveolus. As a result, blood returning to the left atrium will have a lower arterial oxygen content, placing the patient at risk for oxygen transport imbalances. To calculate intrapulmonary shunt, we define total oxygen delivery as the sum of shunted and non-shunted oxygen delivery. We use the letter Q to represent cardiac output, and S and NS to represent shunted and non-shunted blood respectively. Since the shunted blood returns to the heart desaturated, the oxygen content of this blood is the venous oxygen content. The normal or non-shunted blood is oxygenated and returns to the heart with the alveolar oxygen content. Since total blood flow is the sum of shunted and non-shunted blood, we can substitute QT minus QS for QNS. Rearranging and solving for the ratio of shunted to total blood flow, or QS over QT, we arrive at the intrapulmonary shunt equation. This can be used to guide ventilatory support maneuvers to recruit alveoli and improve systemic oxygenation. For almost 4 decades, the fable of the pea monster has been used to illustrate the basic principles of oxygen transport and methods by which you can improve your patient's shock resuscitation. Once upon a time, in a land far away, there lived a pea monster who loved peas. As long as the pea monster got enough peas to eat, he was happy. However, when the pea monster was hungry, he became very angry and terrorized the countryside and its inhabitants. Just imagine a vegetarian Godzilla. In an attempt to keep him happy, the villagers built both a pea factory and a train to deliver peas to the pea monster. The factory processed the peas and loaded them into boxcars for the trip to the pea monster. As long as the train delivered enough peas to the pea monster, he remained happy and healthy. The pea train consisted of a locomotive and 5 cars, each of which could carry 40 peas or 200 peas per train. The train was able to make 4 trips between the pea factory and the monster every minute, delivering a total of 800 peas per minute. As each train arrived at his side, the pea monster was able to eat 10 peas from each of the 5 cars, or 50 peas before the train had to leave to reload at the pea factory. At 4 trips per minute, the pea monster was able to consume 200 peas per minute. Since each train delivered 200 peas, and the pea monster consumed 50 peas per train, each train returned to the pea factory with 150 peas. This meant the pea utilization ratio was 0.25. Another way to look at it was that the boxcars returned 75% full. The reason the villagers paid such close attention to the number of peas returning was simple. When the pea monster was stressed out, he tended to eat more peas. If he ate too many peas, the pea loader was unable to completely refill the cars before it was time to depart for the next trip. As a result, fewer peas were delivered to the pea monster. As each car passed by, the pea monster was able to scoop off the first 10 peas, or 25%, pretty easily. Having been cursed with short arms, however, the pea monster was able to reach the next 10 peas with some difficulty. This was usually a problem only when the pea monster became stressed out and started eating more than his usual number of peas. Much to his dismay, his short little arms were unable to reach the 20 peas in the bottom half of each car. Once he had consumed the top 20 peas, he simply went hungry. There were a number of reasons that pea delivery might be inadequate to meet the pea monster's demands. He might just be really hungry. The villagers might forget to have the proper number of boxcars on each train, or might run the train slower than usual. If the villagers running the pea loader weren't paying attention, the cars might not be filled properly, such that the cars were either not full of peas, or the peas might be dropped onto the ground next to the train tracks. Worse, the train might pass by the pea loader without being refilled at all. One time, A particularly lazy villager failed to notice that he had filled the cars with lima beans instead of peas. And after all, who likes lima beans? If the train left the pea factory with fewer cars than usual, the total pea delivery would drop. As a result, the stressed pea monster's pea utilization would increase even more. If the train engine was running slower than usual, total pea delivery would again drop below normal, forcing the pea monster to eat more peas and raising his pea utilization yet again. When the pea monster was particularly stressed, he would eat double his usual number of peas. Eating 20 peas per car and 100 peas per train, his pea consumption would double to 400 peas per minute, or a pea utilization ratio of 50%. At this rate, the villagers had to work quickly to reload the trains in time to meet the monster's increased pea utilization. If the pea monster was very hungry and the train was not running properly, the villagers were in real trouble. With fewer trips per minute and fewer cars that were not completely filled, the pea monster could still only reach half of the peas in each car, even if he reached into the cars as far as he could. Pea delivery was too low to meet his pea consumption. As a result, the pea monster became very ill, and this story did not have a happy ending. This storybook kingdom is not unlike our patients. When our patients' tissues are stressed due to critical illness or injury, they require increased levels of oxygen to meet metabolic demands and avoid anaerobic metabolism and lactic acid production. Functioning lungs are essential to loading oxygen onto hemoglobin so that fully saturated red blood cells can be delivered to the tissues by the heart. If the oxygen or hemoglobin are inadequate, diseased or injured lungs are unable to deliver oxygen across the alveolar capillary membrane effectively, or cardiac output is decreased. Oxygen delivery at the cellular level will be inadequate to meet the patient's oxygen consumption. End organ failure will ensue, and the patient will have a poor outcome. Just as the pea monster was unhappy when hungry, our patients will be unhappy when their oxygen demands are not met. A hungry pea monster equals increased oxygen consumption. Not enough train cars equals low hemoglobin. That's why you may hear some of the attendings refer to anemia as not having enough boxcars. A slow train equals low cardiac output. Boxcars that are not full of peas are low oxygen saturation. Too few peas is a low inspired oxygen fraction, or FiO2. The wrong peas are either carboxyhemoglobin or methemoglobin. If peas are missing the cars as they pass through the factory, this is an example of ventilation-perfusion mismatch. If the train is bypassing the factory without being loaded with peas, this is an example of intrapulmonary shunt. The human body is obviously much more complex than this fable allows. Each organ is its own pea monster with varying oxygen demands. Some organs don't require much oxygen, while others are oxygen hungry all the time. Our goal as intensive care providers should be to constantly monitor our patients' oxygen demands and strive to optimize their organ perfusion and function at all times.